So what is rescue therapy? So we are moving to the next part of our talk is about rescue therapy. So rescue therapy is the therapy that is used to stop seizures. Either it could be, I will discuss in next few slides about what kind of seizures we use rescue therapy for. Prevent a seizure emergency. For example, status epilepticus is a seizure emergency. So we use rescue therapy to prevent a seizure emergency. And the rescue medication generally don't replace routine medication treatment for seizures. Again, rescue medications are as needed medication. They are created to be used by non-medical people outside the clinic, ER or hospital. And currently we have 3 FDA approved rescue therapies and there are more in development. So when do we use rescue medication? So the first is that seizure clusters, prolonged seizures, status epilepticus, and the last is high risk times. So high risk times are basically if we know a definite trigger for your child, for example, fever or infection, then the provider can work with you and give you a customized seizure action plan to when to use your rescue medications. So discussing about cluster seizures, so there is no consistent definition for cluster seizures. Different people have defined cluster seizures in different ways. However, some of the commonly used definitions of cluster seizures are if your child gets more than 3 seizures in either 24 hours or more than 2 seizures in 6 hours, that could classify as a cluster seizure. They are also called as acute repetitive seizures, bouts of seizures, or serial seizures. And sometimes they can have some warning signs such as prodrome of aura, or sometimes they can have symptoms in between the cluster seizures, for example, nausea or vomiting. And then the person returns to baseline between the seizures. They may not completely return to baseline, but they should return at some baseline level in between the cluster seizures. So let's go to next type of seizure where we require rescue medication is the status epilepticus. So status epilepticus are divided into 2 types. One is the convulsive type. So if the child has seizures more than 5 minutes, we call it as status epilepticus. And then several seizures without time to recover between them. So if seizure comes back to back in more than 5 minutes, again, it's defined as convulsive status epilepticus. It can happen with any kind of seizure. And then in some cases, particularly with symptomatic epilepsy or in early childhood, a child's first seizure can be episode of status epilepticus. And then there is a second type which is known as non-convulsive status epilepticus. This means that the patient is not shaking, visibly not shaking, but still having seizures. Mostly they can have confusion, they can be sleepy, then they can be staring. And sometimes this can be very hard to recognize. And in some cases, it is possible to diagnose non-convulsive status epilepticus with EEG. And sometimes you can't diagnose it by just looking at the child. However, if we have a seizure action plan in place, the person who is with the child will be able to know when he's having non-convulsive status epilepticus. So why do we need rescue therapy? So seizure cluster can sometimes progresses to the long seizures, for example, status epilepticus. And these repeated seizures or status epilepticus or prolonged seizures has very high morbidity because it can cause injury and it can cause because of the brain damage. And sometimes it can even cause mortalities. High rates of emergency department visits and hospitalization if we don't stop their seizures. And then again, the caregivers and the patient have negative quality of life measures if they have to again and again go to the hospital in the emergency room. So that's why we use rescue therapy. So just one slide on who all are at risk of having cluster or prolonged seizures. So again, the patients who are not controlled on two or more medications, which we call it as drug-resistant epilepsy, they are at high risk of having cluster or prolonged seizures and will require rescue therapy. Epileptic encephalopathies, the patients who develop seizures in childhood with brain malformation and other genetic abnormalities. Multifocal epilepsies, if the child has multiple seizures coming from different parts of the brain, that increases the risk of having prolonged seizures. If they had meningitis or encephalitis, some brain infection when they were child. Traumatic brain injury can also increase the risk, and then if they develop seizures at very early age, that can also increases the risk of having cluster or prolonged seizures. And some of the predictable situation or provocation is that if they are really sleep deprived, if there is a lot of stress going on, fever or illness, if they missed their medication doses. Catamenial seizures are the seizures which happens around the time of menstruation, can sometimes increase the risk of having prolonged seizures, and again, alcohol and other recreational drug use can also increases the risk. So what are the medications that we use for rescue treatment? So the first, the currently FDA approved therapies are Diazepam rectal gel, Diastat, Midazolam nasal spray, Nasilam, and the Diazepam nasal spray, which is Valtoco. And then the off-label medications are buccal midazolam, clonazepam, which is oral disintegrating tablet as wafers, and then the VNS, vagal nerve stimulator. We'll discuss in detail about the first three on the left. So ideal drug for rescue medication, what should be the ideal property for that medication? So first of all, they should be safe at their usual therapeutic dose. They should be potent in small volumes. It should be effective against a majority of seizure types. It should be quick, easy, and safe to administer. It should be rapid onset of action within minutes, and they should have low monitoring requirements. So if you see the table on right, just to give you perspective, if you give a medication through mouth, it will take around 45 to 60 minutes to start acting on your body. If you give it under the skin, it will take 45 minutes. If you give under the muscles, which is intramuscular, it takes 30 minutes. Rectal medications will take around 5 minutes. Intranasal is even faster, less than 5 minutes. And then the intravenous is the fastest, which is 1 to 3 minutes. So that's the reason we can't give intravenous medication, because we need a skilled person to do that. We need an IV access for doing that. So the best possible next options are intranasal or rectal route that we can use. So let's say for our patient Duncan, what should we be choosing for him? So he is now 8 years old. He is in 3rd grade. So let's discuss between giving him either rectal diazepam versus nasal diazepam. So diazepam rectal gel is a semi-solid preparation. It's administered via plastic syringe applicator. This was approved in 1997, so it has been used since a very long time. We can repeat one more dose in 4 to 12 hours if he had another seizure in 4 to 12 hours. What are the pros, what are the advantages? So the dose is already predetermined, so you don't have to calculate the dose when he's having seizures. It has long-term track record as it is approved in 1997. It is rapidly absorbed in the body, can be given in conscious and unconscious patients, can be advantageous in patients with post-ictal nausea and vomiting. Some of the disadvantages of rectal diazepam gel is that it requires another person to administer. The delivery route could be difficult in some patients, especially if they are large patients, if they are on wheelchair, and if they are moving a lot during seizures, it may be difficult to administer this. And then sometimes they have societal implications. For example, the school teacher, there are a lot of kids around in the school, in the class, and the school teacher may find it difficult because of the societal implications to give if the child is older. So let's discuss about the next option, which is diazepam nasal spray. So again, it's formulated with non-ionic surfactant. It can be used 6 years and above. It can be repeated again one more time in 4 to 12 hours, same as our rectal diazepam. And then it has all the advantages that diazepam rectal gel has. And again, and to add to it, nasal vasculature provide ample and direct access to the bloodstream, so it's slightly faster. And again, absorption is about as fast as intravenous route. And it's very easy to use, so that's the biggest advantage of it. And again, The only disadvantage would be it requires an open nasal passage. So even if the child has nasal congestion or some seasonal allergies, still we can give it as long as they have open nasal passage. So again, just to quickly discuss about rectal diazepam, because that's the one that we use more frequently, and it's so just going to give you a little bit more more information on rectal diazepam. So first and foremost thing you need to do is, when you get a rectal diazepam from your pharmacy, is that to check your dose on the display window, which is right here. The next thing you need to do is that you need to make sure that there is a green ready band present on your injection. Store at 25 degrees Celsius, around 15 to 30 degrees Celsius range, or 59 to 86 Fahrenheit. Here in Louisiana, the temperature can go up to 90s and 100s in summer. So I would advise my patients to avoid keeping in the car, because if you keep it in the car, it can get deactivated. In the colder weather in Alaska and some other northern region where it can go to 0 to minus 30 degrees Fahrenheit, it can again get deactivated. So try to avoid keeping it in the car. Keep one at home and one at school, and keep it with you till it expires. Even if it's not used, make sure you keep it with you, because you never know, you may have to use it. Again, this is the dosing for rectal diazepam. Generally, it's based on their age and weight. How to administer rectal diazepam? So the first is put the person on the side where they can't fall. The next is you get the medicine, and then they get the syringe, and after that you push up with the thumb and pull to remove the cap. The next thing is you lubricate the rectal tip with lubricating jelly, and then the turn person on the side facing you. And after that, you bend upper leg forward to expose the rectum, separate the buttocks to expose the rectum, and after that, gently insert the syringe tip into the rectum. And now I always like this rule of 3, where you always count up to 3. So when you inject the injection, count 3, and then slowly count 3 before you remove the syringe, and then you count 3 and hold the buttocks tightly together to prevent the leakage. So now let's discuss about Valtoco. So it's much easier to administer Valtoco compared to the 12 steps that we discussed for rectal diazepam. This only has 4 steps. So step 1 is you remove the blister pack by peeling back the corner tab with arrow, and then remove the nasal spray device from the blister pack. Then the next step is that you hold the nasal spray device with your thumb on the bottom of the plunger, and then your first and middle fingers on the either side of the nozzle, and do not press the plunger till you put the nozzle into the first nostril. And again, you can use the rule of 3. You keep it on for 3 seconds and press the bottom of the plunger firmly with your thumb to get the Valtoco in the nose. Now, Valtoco comes in strength of 5 and 10 milligrams. So if someone is older and then they may need higher dose. In that case, you may have to use both the nostrils. So 5 milligrams from one nostril and 10 milligrams from another nostril if you are giving 15 if that child needs 15 milligrams of Valtoco. And the next drug is Nazilam, which is approved for the kids more than 12 years of age. It's exactly similar to Valtoco. And then currently, as you know, there is some of you may know that there is a rectal diazepam shortage going on. So for the kid, especially between 2 and 6 years, where you can't use nasal Valtoco, we need to find out alternatives. So right now, we are recommending using clonazepam wafers for kids between 2 and 6 years of age who can't get rectal diazepam due to shortage. And these are very easy to use. They are wafers. They dissolve in saliva very rapidly, and so if there is a caregiver who is giving this medication, you use your dry hands, and then you just place the wafer on the side between the cheek and teeth, and then you press it, and it will automatically dissolve the tablet. And then it also acts very fast, and the dose is written here, and it's very easy to administer, and it's pretty cost effective. And then Epilepsy Alliance of America has nice videos that demonstrate how you can give all the things that we discussed. So it's very practical, very nicely demonstrated videos if you would like to learn more about it.